Welcome everybody to this next town hall from Maryland chapter, American College of Emergency Physicians, President-elect Carrie Forrestall. And with us tonight, we have Ted Delbridge, MD, MPH, who is the Executive Director for the Maryland Institute for Emergency Medical Service Systems. So I'm not going to spend a whole lot of time talking. I'm going to leave the time for Ted. And the questions we handle, put them in the chat. I will ask them in turn to Dr. Delbridge so we keep things on task. And with that, Dr. Delbridge, the floor is yours.
Okie dokie. Can you see my screen okay?
Yes.
Awesome. I'll make sure I did it right. I thought I'd spend a few minutes just telling you about some of the things that we're following along in the EMS system, especially as it has to do with interfaces with hospitals and emergency departments, and give you the EMS perspective of emergency department and emergency medicine. And please feel free to stop me along the way and ask questions. Otherwise, I'll just ramble. So hopefully be the bazillion foot view. Just for your information, last year in 2025, the Maryland EMS transported 586,000 patients to Maryland emergency departments. And you see there how they were distributed. Anne Arundel Medical Center is the busiest receiving center for EMS patients, followed by Frederick, Franklin Square, and Baltimore Washington Medical Center. And you can see as it goes, and I'll stop for a second so people can find the hospital they're interested in. But this really realized about a 0.7% increase of EMS business in terms of transports from 2024. The EMS business over the past 6 years has increased by about 8% overall. You can see the dip in 2020 associated with COVID. I'm going to compare this or put this in perspective in terms of emergency department patients here in a little bit. But ED volumes in the state overall have actually gone down, while the proportion of ED business that belongs to EMS has gone up. Through so far year to date, 2026, there have been 155,000 patients transported to Maryland emergency departments by the EMS system. About 24% of EMS contacts in the field don't result in a patient transport at all. Those are patients who refuse service or for whatever reason don't go to the hospital. And this chart shows the distribution of how the EMS clinicians prioritize patients. So priority 4 is this thin red sliver you can hardly see. Those are folks who are deceased or were defined to have no medical emergency is actually the definition. The yellow pie piece is priority 1. Those are patients who are felt to be a life-threatening condition by the EMS clinicians. Priority 2, not so very much. And priority 3 are more non-emergency, need care, sometime today kind of patients. You can see that makes up the majority of EMS patients. I realize, hope you do, this is entirely subjective. And I listen to the radio often and listen to the reports the EMS clinicians are given to the hospital emergency departments and hear them define patients with a stroke as a priority 1 patient. Those patients definitely are emergency, sort of in emergency need, but I wouldn't necessarily classify them as life-threatening. So point being that this is a subjective thing and just gives sort of a general gestalt of the EMS system, if you will. I mentioned 580-some thousand EMS transports to hospital emergency departments. The Maryland emergency department census in 2025 overall was 1.98 million people. And you can see there where the busiest EDs in the state were. Again, Anne Arundel Medical Center, not only the busiest EMS receiving station, but it's the busiest emergency department in the state, followed by Johns Hopkins, TownHall Peninsula Regional Frederick Health, and BWMC. And you can see there how the distribution goes out from there. So EMS folks are often wondering, there's often this perception they have that they represent a huge portion of ED patients, that the emergency department should be more receiving of them because they're bringing them all their business. And a different payment model, bringing a lot of business might be a good thing. In Maryland, more business just really means more business. But you can see there that the overall proportion of ED patients that are made up of EMS folks across the state is about 28.6%. And the hospitals with the largest proportion of their patients made up of EMS patients are Johns Hopkins Bayview, UPMC Western Maryland, Northwest, Grace Medical Center, and Franklin Square, followed by Frederick Health. The average ED sees about 26.7% of its patients are EMS patients. You see how it's distributed across the hospitals. One of the things that we pay really uber freaky close attention to is the concept of the EMS to ED transfer of care interval. That's the time it takes EMS folks to transition care of their patients from themselves to the ED staff. And the goal is that they can do that within 35 minutes, 90% of the time. And we hear often, well, the hospital's average is not bad, 20 minutes. But that's what happens half the time, right? We're looking for what happens 90% of the time, sort of like characterizing a highly reliable organization. And the red line across there is 35-minute mark, always realizing there's going to be outliers and there's going to be existential circumstances, exigencies that make it hard to transfer care promptly when the patient on the stretcher isn't particularly in acute need and the goings on to the emergency department are particularly busy and critical. That represents the 10% beyond 35 minutes. But you can see there the hospitals on the left do a particularly good job at this metric. About 40% of the hospitals meet the goal, and the ones on the right, not so very much. And some of the ones on the right, this is a perennial challenge they have to pay attention to this. And there go was part of the motivation for the directed triage protocol that we implemented a few years ago. That's not uniformly used throughout the state. I sort of wish it was. In my last life, running a really busy emergency department, I always wondered why EMS folks always bump to the front of the line. I would be aware of a patient in the waiting room who was 75 years old with abdominal pain and a marginal blood pressure, and knowing that patient needed urgent help. And the next EMS patient would arrive who really just needed to ride to the hospital, and then the nurses would bump them to the front of the line to sort of accommodate the EMS folks. And it bummed me out that the lesser sick patient was getting serviced quicker. And that is the reality, I suspect, in most every emergency department who accommodates sick people and large volume of EMS patients. So the directed triage protocol was really two-part. One was to not be deluded into the notion that every EMS arrival is sicker than the patient who got themselves there by some other means. So to not disrupt the ED flow of patients, and also to help facilitate that transfer of care interval so that EMS isn't hanging out with a patient who doesn't need immediate attention and really could fall in line and they could free themselves up to do their next thing in the community. So we really look for champions for that. This is information that we provide to the HSCRC, the Health Services Cost Review Commission, on a monthly basis. It's really busy. Every cell represents a hospital in a month. And realize that green is good, yellow, medium, not so good, and red is not good at all. Red are cells where the transfer of care interval was more than 65 minutes for that month at the 90th percentile. And you can see on the left how many red, yellow, and green cells there were in January to March 2025 and how many there are in 2026. Big difference. We really are appreciative of the hospital emergency department's effort to pay attention to the necessity to free up EMS so they can go back out of the world and do what it is they're supposed to be doing. And this is a different way of looking at the same thing for the past 3 years, 2026, 2025, and 2024. You see how red's gone down, green's gone up. It's a little tricky to assess this at this particular time of the year because some of this has to do with respiratory virus season and how it times out. The hump on the left is this year. The hump on the right was a little bit later last year, and so likely affecting ED volumes and the ability to move patients through in different months of the year. Fortunately, respiratory virus season, as I'm sure you all know, has waned quite a bit, although RSV, I think, is still a problem. One of the problems is that what EMS encounters and what you live with every day are the number of boarding patients in the emergency department. We, since 2020, 2019, have been exercising the MEMRAD system, the Maryland Emergency Medical Resource Alerting Database, where we can query hospitals about, usually it's designed to query hospitals about immediate needs, do a quick bed count because it's a multi-casualty incident, find out how much rabies vaccine is available in hospitals, stuff like that. Meant to be exercised once in a blue moon. We've been doing it daily. Well, we don't do it on the weekends anymore, but we've been doing it since 2020, 2019, every single a day, except for weekends recently, to ask hospitals census information and get a biopsy of hospital emergency departments specifically. And we're particularly interested right now in number of boarding patients. And we don't define boarding. We understand this to be when a patient is done with their emergency department care, ready for whatever's supposed to happen to him or her next, and whatever that something is, whether it's go to the ICU, go to a floor bed, be transferred to a different hospital, go back to the SNF, whatever it is unavailable for some kind of reason. There's no time expectation. It's just that we allow the hospitals to define that for themselves. But basically, it's a patient who's stuck and not able to do whatever is supposed to happen next. There are about 1,920 emergency department treatment spaces in the state of Maryland. And when more than half of them are filled up on any given day, and this biopsy is done mid-morning, so it isn't even rush hour in the emergency department yet, kind of thing. Doesn't represent worst case scenario. We know this is gonna be a bad day. The yellow arrow, 400 boarding patients at this time of day, we predict that to be a pretty good day. 1,000 beds, 1,000 boarding patients and beds in the ED, that's gonna be a problem kind of a day. And this is a recent snapshot. The other one was the day we hit 1,000 was sort of a record back in January. This is more recent and normal, where we're between 400 and 500 patients per day boarding in EDs. But boarding is a real concern. I know you know, I'm not telling you anything you don't know. And so last summer we rolled out the emergency department advisory system. This replaced chats. Chats in its day was awesome, I'm sure. I wasn't here, but it was awesome. The red and green, red and yellow alerts, blue alerts, all that stuff. But it's very subjective. And if you were an EMS clinician, you could walk into one emergency department that was on red and yellow alert, and the nurses and physicians would be pulling out their hair. It'd be like everything was on fire. And then an hour or two later, you go to a different hospital that's also in yellow and red alert, and you got to go to them anyway because everybody's on yellow and red alert. And so the expectation was nobody was going to come if I was the hospital, but that was an unrealistic expectation to have for the EMS system, who had to land someplace. But they would go to the next place, and they'd be on the same alert status, and everybody would be hanging out, drinking, sipping coffee, and having a good day. And part of the reason for that was the subjective nature of it all. This makes it a little bit more objective. It's not totally super awesome, but it's pretty much a lot better than it was before. Where the ED index, the census index, is derived from the census in the emergency department compared to the available treatment spaces in the ED, which we settled on with every hospital before we published this. And so the staff goes into the MEMRAT system and puts in how many patients there are, and they can update it as often as they want to. And it calculates the census, the ED index, based on that relative to the capacity of the emergency department. And a 4 represents a hospital that's above 130% of its capacity in the emergency department. And it's counting patients in the waiting room, those who are boarding, stuck in a hallway, whatever. And what we've seen since we implemented this is that one is the EMS system is using it. You can hear on radio traffic that they really are paying attention to who's at what level, in addition to not only that, but how many ambulances are currently at the facility and how many are en route. So they get sort of a real-time snapshot of the ED, and it really can help them decide where they are likely to encounter a most efficient experience for their patient, given the constraints of patient condition and hospital expertise and stuff like that. The other thing it's given us a better glance at are the portion of time hospitals spend in some alert status. These are the hospitals through so far in April, early April, that were on EMS reroute greater than 100 hours. And it turns out 100 hours was, if you look at all the data, is a natural break point. And this probably doesn't represent as much about hospitals and hospital ED efficiency and things like that as it does the local EMS jurisdictions' propensity to use this as a tool to help guide their own traffic. So you'll notice that a couple of these hospitals are, for example, relate to Anne Arundel Fire Department. And so I think Anne Arundel County Fire Department has more of a likelihood to use reroute as a tool to help guide themselves into where they're going and not going any particular time of day. But you can see there how the other hospitals that are part of the system. Another glance at this, there are some hospitals that are busting at the seams like all the time. And these are the hospitals that spend more than 50% of the time in level 4, which probably reflects two things. One, they're busting at the seams, and two, they update EDAS often, meaning they keep their status up to date. But you see where those places are. And those are good places for entities such as the HSCRC and the Healthcare Commission to look at resources that are available in those communities. One of the issues I know everybody's interested in is how EMS flows, and do they pay attention to this stuff, and how things evolve over the course of time. This is a particularly busy slide. I'll try to dissect it really quickly. Every line represents a hospital, and the y-axis are a number of ED arrivals by EMS in the year, and of course the years are across the bottom. The hospitals listed here were either in the top 10 receiving hospitals in 2020, or they're in the top 10 receiving hospitals in 2025. And you can see there it's not stagnant. The blue line is Anne Arundel Medical Center, and you can see the number of ED arrivals at Anne Arundel has gone up every year since 2020. The purplish line at the bottom is Capital Region. You can see there was a big dip in 2022 and 2023, and then making a comeback. And what this says to me is that EMS responds to the efficiency of the healthcare system within those particular hospitals. And it also is probably a reflection of the demographics of the community, hospital resource availability, and how the hospitals take themselves on and off reroute and things like, capacity alerts and things like that. This is another look at the same thing. In the past 5 years, Capital Region, St. Agnes, and Franklin Square have all seen a reduction in EMS traffic come their way. And you can see all the rest of the hospitals have seen an increase in EMS traffic. And I mentioned earlier that ED volume in Maryland has gone down over the past couple of years, and I'll show you a graphic here in a second, while EMS traffic has actually gone up. I'm sure you all know that Maryland suffers from, or has is noted, suffers from having one of the longest ED throughput times of any state in the country on average. This is OP18, which represents the median time for emergency department arrival to discharge for discharge emergency department patients. And if DC was on here, DC is one notch longer than Maryland. But amongst all the states, Maryland has the longest ED throughput of any state in the country. At the same time, it has one of the lowest per capita ED utilization rates. The national average is 422 ED visits per 1,000 population. Amongst Maryland is 293 per 1,000 population, third only to Utah and Nevada. And so there's been a lot of effort over the course of time to divert patients from the ED to other healthcare resources. That has apparently happened in Maryland to quite an extent. And another look at that is here where the yellow line's the US experience, and the orange line is the Maryland experience. And you can see how Maryland has dipped way down. I ran out of graph, and Maryland continues to be on the decline in terms of ED volume per capita relative to the country. In the past, we have done a lot of work to try to get EMS to go to destinations other than emergency departments, particularly urgent care centers, when those seem like options. I'm here to tell you it doesn't really work so very well. There are a number of challenges to this. One is geography. So EMS jurisdictions are generally county or city entities, and the urgent care place that's willing to accept EMS patients is located on one side of the jurisdiction, where the EMS unit's taking care of a patient on the other side. And so it's not likely they're going to drive past 2 or 3 hospitals and go to an urgent care center. The other problem is variability. While emergency departments generally connote a general sense of uniformity and at least the critical care resources they can bring in the first couple of minutes of a patient being there, and we categorize emergency departments by a lot of other measures, stroke centers, cardiac centers, things like that. There's quite a bit of variability in urgent care centers. Some can do x-rays, some can't. Some can do lab work, some can't. And we'd be relying on EMS clinicians to make those judgment calls on a case-by-case basis relative not only to the patient, but to the facility place. Third thing is logistics. An ED is available 24 hours a day, 7 days a week. Urgent care centers are available till 9 o'clock, but they don't want to have any patients till 8 o'clock. And the EMS folks have to get clearance to take the patient there before they arrive. And so that's problematic. And the fourth thing is investment. And what I mean by investment is sort of an expectation. We're all familiar with the Ottawa ankle rules. They work really well. If you don't have tenderness over the posterior lateral malleolus or the posterior edge of the medial malleolus and the patient can bear weight, don't have those things, you don't need an x-ray. That's great in my experience when you're on the sidelines of your son's soccer game and somebody sprains an ankle and you can say, oh, not tender here, can walk. Don't go to the hospital. You don't need an x-ray, ACE wrap, ICE, elevate, that kind of stuff. It's much harder to apply the Ottawa ankle rules when somebody's sat in the waiting room for 2.5 hours and they are invested in getting an x-ray of their ankle. There's just no way you're going to talk them out of it. That's the investment in the urgent care experience where people are invested in going to the hospital. They call 911. They have an expectation that's what's going to happen. So do the EMS clinicians have an expectation that's what's going to happen to them too. And so that doesn't go. So the experience in Maryland has been over the past year, the EMS system has taken 82 patients to urgent care centers. They've tried really hard to make that happen. They've responded to urgent care centers almost 11,000 times to extract patients from urgent care centers and take them to emergency departments. And so if you're an EMS clinician in the field, your experience is an urgent care center is someplace you go to get a patient, not someplace you go to take a patient. And so that experiment doesn't necessarily pan out. That is in the backdrop of someplace like Adventist Healthcare Germantown Emergency Center, which is set to close on July 1st. The GEC, as it's affectionately known, is in Montgomery County. It sees a smidgen over 20,000 patients a year. 2,000 of those patients arrive by EMS, and this resource will go away. The theory, at least in part, of the Adventist healthcare system is that, part of the reason they're closing is because they sense that the acuity of their facility isn't on par with other freestanding emergency facilities in the state and around the country. There aren't enough high acuity patients to justify it as an emergency department, and they believe those patients can be just as well cared for at urgent care centers or other non-emergency facilities. When it was built, Holy Cross Germantown wasn't in the picture. Now they're in the shadow, and they feel like the higher acuity patients are going there and not to the GEC, and so they're going to close up. But they expect that nearly 20,000 patients will migrate to other nearby emergency departments and/or urgent care centers because of their low acuity nature. And so we'll see how that pans out. All that is in the backdrop of the work the Health Services Cost Review Commission is doing with this ED Wait Time Reduction Commission to try to identify strategies that improve upon that 250 minutes I showed you and make EDs more efficient at managing the patients who come to them. This is something the EMS participates on, so do a number of your colleagues around the state who are all part of defining strategies to do work. I'll tell you, so far the work of the commission has been mostly in polishing data, and so it's got a ways to go before it's actually defining strategies that are effective. In other news, and some of you may be familiar, we have embarked upon identifying emergency departments in terms of their ability or their readiness to manage pediatric patients. We're categorizing. This is a voluntary thing we're hoping hospitals will take advantage of. It does two things. One is makes it more clear to EMS clinicians what hospitals are prepared to take care of what caliber pediatric patients. The other thing is it helps hospitals organize around their readiness to manage pediatric patients. So there are three categories. The pediatric ready emergency department is there for stabilization and care of general patients. The resource hospital has the ability to overnight observe or provide inpatient care to children, and a comprehensive pediatric hospital has an ICU and is prepared to do surgical care. So far, we've had about 19 hospitals express interest. We've recognized 4 facilities, and a couple other ones are in the works. There's a pediatric emergency department, pediatric ready emergency department at Northwest, a resource hospital at Meritus, and comprehensive hospitals so far are University of Maryland Medical Center and Sinai. And the Hopkins site visit, I think, is coming up. And so we hope to have 20 hospitals classified by the end of this calendar year, and I'm sure we'll get there. In other news, and getting close to the end, for those of you who are wondering, we all know that lactated ringers isn't blood. The challenge is getting blood into the field. MSP has been delivering whole blood to its patients for almost 3 years now. They've just crossed the threshold of helping 300 patients with more than 350 units of blood. Since last January, they've given more than 158 units of blood to 128 patients. And eight jurisdictional EMS operational programs also have whole blood available to them in the field. You can see there who they are. What's interesting is that only about 60% of the patients they give blood to are trauma patients. A large portion of them are medical, meaning GI bleed or bleed from some other source, or OBGYN cases. What we didn't do particularly well when we rolled this all out was get really systematic and statewide about monitoring the effectiveness of doing this. I mean, there's a lot of anecdote, a lot of good feelings, but not as much data of the kind that would be really robust that we would like. But there's really good evidence the shock index decreases. A lot of patients live who we think would have not lived if they had not had blood. And we're pretty sure that it reduces a lot of transfusions that it would otherwise occur in the hospital. And so it's a pretty good deal. And in the theme of rolling out, you may be aware of the Rural Health Transformation Program, and Maryland got $168 million allocated to it for the current fiscal year. We were asked to supply some ideas for how EMS could contribute as the plan was being developed back in the fall, late fall. We submitted a bunch of ideas, and two of them took hold. The Rural Health Transformation Program in Maryland exists in three buckets, or columns, if you will. Initiative 1 is transforming the rural health workforce, and there's work going on there. Initiative 3 is empower Marylanders to eat better. There's work going on there. Initiative number 2, which is where EMS is involved, is in providing better equipped trauma response and a mobile health in each rural region. And the better equipped trauma response, that rolled out to be whole blood. And for the current fiscal year, we've been allocated $969,000 that we're spending in 13 different jurisdictions who have raised their hand and said, we can do whole blood if you give us some cash money and some tools to do it, or we do whole blood and we could improve our deal if we had more resources. Can't pay for stuff that was already going on, but it can pay for new stuff. And so there are 13 jurisdictions. The other areas in mobile health, those are transformation grant dollars. So $20-some million has been allocated for the current fiscal year. It's being held back for local health departments in each region to apply for basically competitive money to do mobile integrated health and some other things. And so it requires EMS to collaborate with the local health department, which is what most of the mobile integrated health deals do already, but it will require them to collaborate for the purposes of getting grant money. There are currently 14 EMS agencies across the state that do mobile integrated health or community paramedicine. We have intentionally, as this has evolved, let it be way open and blank slate for them to do their thing. I will tell you that at their core, they're all particularly focused on limiting or heading off calls to 911. That's generally their focus, and/or follow up recently discharged patients from hospitals, but with the idea that they're heading off the call to 911. I think the next generation of this is to get better definition, emphasize core common elements so that we talk in the same language across jurisdictions, and enhance the attention to evaluation and central indicators so that we're all evaluating the same kind of thing and not just counting contacts, but measuring real outcomes to determine the effect of what it is they're doing. And that's my spiel. I'm happy to try to answer any questions or talk about whatever you want to talk about.
Okay, everybody, if you want to put some questions into the chat, I'll start with another feel-good anecdote for you. We actually had a postpartum hemorrhage that benefited, it saved her for the whole blood in the field. It was a very nice save. So kudos for that. That's out in Wacomico County where we are.
That's awesome. Thanks.
So, all right. Anybody have any questions? I don't have any questions in the chat so far. So that's a very thorough presentation then.
I will tell you, I know one of the things I didn't really touch on that was a question that had come up was the idea of EMS folks taking patients back to facilities where they might have recently come. Like they had care someplace, they just got discharged from the hospital. Should the EMS guys go back to that place when there's an acute need, or can they take them anywhere? And the answer to that is they need to go back to where they came from. But that hasn't been up till recently uniformly appreciated by the EMS folks. I was spending time in the field. This is now quite some time ago. And I was at one hospital, and had met EMS folks from the county I was in earlier in the morning. And now I'm in a hospital that is, I don't know, at least 20 miles away from where I saw them. And they bring in this patient who's really non-communicative and chronically ill. And so I asked, like, what are you guys doing all the way up here? Well, the hospital closest to us is busy, and this one's not quite so busy. It was busy anyway, I can tell you. It was busy. And I say, what's the deal? We just got out of the hospital yesterday. From where? The other hospital that was closest to us. Why in the world would you ever come here? Well, because it's not as busy. We'll get in and out of here faster. And what the EMS folks have a difficult time appreciating sometimes is like, stitch in time kind of deal. I mean, they look at the quickest turnaround now. They don't realize that what they're doing is they're bogging down the system down the road. And so that was part of Tim and I communicating to them. The really repatriation, if that's the term that people use, is really in their best interests as well as the patients. And dropping a patient off at some place where they don't have an experience with the physicians aren't the same, the ability for continuity of care isn't the same. That one of two things happens: patient gets taken care of at that place, and if there's not some subspecialty reason to be there, they're getting a whole new group of people have to be familiar with that person. It's really a disservice to the patient. Or the ED staff makes an attempt to get the patient back to where they should have gone in the first place, and bogs down the entirety of the system as they're not taking care of patients, they're doing perfunctory logistics work, trying to get the person back to where they came, and the person's occupying space in the ED where they shouldn't be. And so we are fans of getting the patient back to where they're supposed to be the first time and not ricocheting around.
That sounds good. All right. So from Dr. McCarville, we have, how did MIEMSS come up with the guidelines for the turnaround time to DC of 180? Is that a comprehensible? Pat, why don't you unmute and explain a bit?
Yeah, we are now held to expectations of discharging our patients in 180 minutes, and they're basing it on a guideline they say was provided by the state at 180 minutes. And it's a very, I'm just wondering how we came up with those numbers, because it's a very tight turnaround. And if we can look at thinking that and putting some data into what other, putting out different numbers and what would be reasonable.
I can tell you that that's not a MIEMSS thing. First I've heard of it, but I can also tell you that I think it probably falls in line with some of the work the HSCRC is doing, and under any goal in terms of emergency department throughput is being championed by folks who are paying attention to national norms. Oops, lost my. I was going to try to look at a slide that I showed.
Yeah, is it the like median of the national OP18 would be my bet.
I think that's right.
It might be a national. Yeah, I think that's a national number.
Yeah.
Based on your ED size. I think the HSCRC has previously had put out with the EDI efforts like a general aim to move towards national numbers, but I don't think they were that. Pat, that's pretty aggressive. Yeah, it depends on the size of your ED, but that might be sort of one of the numbers for us. Depending on the size of your ED.
Yeah, I don't know where it's from over there. I just heard, and maybe it's not coming from MIEMSS, and maybe it's coming somewhere else. Which I was just trying to get a understanding of the number, because it never made sense to me. And so, not saying it's in here.
I can tell you, the OP18 value for Pennsylvania is 183 minutes, and that is Pennsylvania is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 states better than Maryland better in those terms.
Okay. And Dr. Bond had said it was a national number. He added that as well. Welcome, Michael. All right. The next question is from Dr. Bond. Is there work on making EDAS update automatically based on hospital census? I noticed that many hospitals are not updating regularly, so they are auto downgraded over time, and EDAS number is not an accurate representation of the census.
Yeah, that is a limitation. So it's a long answer. The long answer is that we had access to a system that would have done just that, and we couldn't get the hospitals to sign on. They, at the time, didn't want their data to be disseminated in that way. It would have counted bed occupancy in the hospital, would have counted ED stuff. It linked up with EHR. Didn't matter which EHR the hospital used. We had to do this. We had a grant from the CDC to make it happen. We had the money in hand. We had the IT contractor ready to go, and we couldn't get two of the biggest health systems in the state to engage. They engaged to tell us no, they were never going to do that. And so that's sort of where we got stuck. And that's how we ended up with EDAS in the format that it is. And I agree, the hospitals that spend more time on red or level 4, probably level 4, as I mentioned earlier, because they update often and they create an accurate representation of what's happening in the ED. And some of the other ones downgrade over the course of time and never go back and update often enough. I think it's something we're paying attention to. I don't know that we have the bandwidth to tap into EHRs to make it happen automatically from our end. I think if hospitals have the impetus to do that, we're more than happy to receive the information any which way they send it to us.
Okay. Anybody else have any questions? Whoop.
Hey, this is Amit. Sorry, shift run over. I'm a little late. Thank you for the town hall here. I had two questions. I'll start with the first, and I apologize if you covered this, but one of the great services that we had, over a year ago was the Critical Care Coordination Center, and the opportunity to kind of coordinate with our colleagues across the state and look for critical care beds. So, has there been any discussion on that? I think it was a grant-based program, and they were looking at the hospitals maybe support. Has there been any discussion on potentially bringing something like that back, or an iteration of it through the state?
Yeah, the C4 was awesome. I've never gotten a negative comment back about the C4. Everybody's just like you've expressed. It was of great benefit and saved a lot of logistic hassles from the emergency department perspective. We tried to make this. We tried to present it so the state would pay for it, so that MIEMSS could continue to carry it on, and got denied. It was considered a COVID thing, and as administrations change, they like to shed stuff. Gets attributed to the administration prior to them. Seems like maybe. Anyway, so the current focus is on acquiring federal funding or grant money to get it cranked up. There's a lot of interest in doing that. We hear often from the trauma folks that they have great interest in making that happen. There's a concept called MOC, Medical Operation Command Center, Control Center, that is championed by the feds that we're hoping to tie into. And so we're constantly on the lookout for grant money to make it go again. And first opportunity, we surely will.
So one of the things I'll share with everybody is Dr. Susanna Martin, who's our president-elect, is a pediatrician, emergency medicine pediatrician, and we're starting discussions to see what we can do on our end about advocating for C4 funding through the legislature. So along with our kind of political action guys and policy guys, along with Dr. Martin, we're going to be looking at that, and hopefully we can reach out to you and get some synergy there. So
information, the way we were running it cost about $2 million a year. That's what makes it go. So if somebody starts talking about cash money, and what I've previously been told is that is budget test. That was an idea when we were back talking a little while ago about the Rural Health Transformation Program. That was one of the ideas we proposed for that, was we thought we could improve rural healthcare a lot by having a C4 kind of thing, but that idea didn't take.
Yeah. Has there been any look at how much money C4 saved as far as boarding patients and just all the things that go along with patients being backed up in the system?
Not in the way that would resonate with Brooks.
Hmm.
A lot of qualitative stuff, but nothing quantitative.
Okay. So yeah, so like I said, we're this is moving forward. We're looking to advocate for legislation as opposed to just kind of endorse or not endorse. So that's what we're going to be working on this year. All right, let me just look through here and see.
Gary, can I ask one more? Sorry if I monopolize.
Oh yeah, no, please.
Maybe maybe based on my own sort of my own being Frederick Health's local trauma, and our cyber security event that occurred about a year ago. Sort of looking forward, there was a lot of great coordination with our EMS partners in kind of getting us through that. And it was a lot of figuring it out on the fly, and no one really knew how long that was going to go on for. And I think all of us are vulnerable to this happening at each institution. You might one day walk in and now you're down, and we don't know when you're going back up. And so at the time, there was a lot of sort of ad hoc coordination going on between like Frederick County and some of the neighboring institutions at Meritus and Holy Cross and other places. I guess maybe just to start the conversation, is there been more of a sort of formalized thinking through MIEMSS in terms of if a sort of regional center goes down for a prolonged period of time, and having access to now like the version of EDAS that is out that might display more objective data, because I can tell you we leaned on our sort of hospital partners for a bit, but there was always kind of like, I think, a question in the back of their mind in terms of like data transparency, like how busy are you when you're not receiving EMS traffic for more than a few days. And so it requires just a lot of like phone calls and that kind of thing. So kind of a long-winded comment, but I guess just thinking about like cybersecurity events or things that take a hospital down for a long time. Has there been any discussion like regional coordination of ambulance traffic in an event like that?
So we have discussed somewhat regionalization and get people more cooperating and sort of plan ahead. One of our partners for that kind of event with the OP&R section of the health department, plans for preparedness and response. And one of our pleas with them is where they plan for like the big catastrophic thing. And one of our pleas has been we need more exercising and planning around cybersecurity events and just IT catastrophe in general, because the big mass explosion, while it's theoretical, could happen. The cyber thing is a certainty, and it's going to happen just like you just described. And so we're interested in more planning and exercising and consideration of what we do when those things happen, because it's just a matter of time. Right. And IT stuff going down is the number one reason hospitals go on condition black, or many disasters used to be called. And that's like the number one thing, and it always happens in the middle of the night. It's more routine than you might imagine.
One of the, I think, really great things I didn't know and I learned during this event was that our partners and the captains from Frederick County had shared they do have the ability to stand up an internet, or have the ability to stand up like an internet Wi-Fi. Now that never really happened because I think they couldn't sort of our being like the IT at the hospital couldn't really kind of navigate how to do that in a secure fashion. But it was something I thought was a great option, which was if your internet went down, there was the ability to get on the Wi-Fi through what and you probably obviously know more about this, but somehow you could stand up like a Wi-Fi for the ED. So I felt like there was like opportunity we didn't take advantage of through we being the hospital at that time that we probably should have.
Yeah, and institutions, when they're in those circumstances, tend to sort of clamp down and be quiet. And I think we need to be better at helping them understand what resources are available so they know what they can ask for legitimately and not be shamed into going into a corner and shutting down.
Yeah,
All right.
fully agree.
Dr. Stone has shared a link to an article that he was an author on, if anybody wants to check that out. All right. Any other questions? We're coming close on time now. Did I miss anybody? Anybody else want to chime in? Dr. Mann, did you want to say anything about your upcoming town hall? Put you on the spot. I apologize.
Yeah, we've actually had to put it off until after the upcoming conference, the Maryland conference coming up. But we'll probably be doing it in September. We're going to be speaking with a group that we invite, and including everybody here, but also some key players that have knowledge and background regarding violence in the emergency department. So pretty hot topic currently. So we're going to send information about that out, a flyer. You'll probably see through Adriana in the near future about where and when. Likely the end of September. Is that what we talked about, Adriana? Yeah. Okay. Yeah. So that's kind of a little synopsis.
Terrific. All right, then. I will look one last second here. We have EMS question from Dr. Eric. Okay, so EMS person question. Any consideration or elimination of replacements for alternate destinations, such as, I'm having problems, the windows are getting very tiny as things are going on. Officer to decompress the EDs and provide some on-the-spot medical reminder medical guidance, i.e. not recalculate LAMS repatriation questions. That comprehensible? Or Erica, do you want to jump on and clarify? I've got 2 lines I'm trying to read through.
Sure. So the question I had was more, especially with how unsuccessful the urgent care, the alternate destination has been. Whenever I used it in the past, the urgent cares would always decline to accept the patient. So we'd have to transport to the emergency department anyway. Has there been any look at a regional or state level and doing anything like more treatment in place or nurse triage lines and things like that to try and redirect those patients that may meet urgent care criteria?
So a couple of things. One is where we have invested our effort really is 2 parts: in encouraging and authorizing EMS to use alternative destinations. I should have said this. They're unrelated to urgent cares, but like mental health facilities. We've had some success in like behavioral health facilities that will take patients. And in those cases, the emergency room is generally absolutely the wrong place. It isn't just like the emergency room is too much for those people. It's like the wrong place to be. And so where we haven't had success with urgent care, we've had some success in those venues. We've also been supportive. We haven't done anything on a statewide basis yet, but we've been supportive of inclusion of telehealth encounters that are initiated by EMS personnel at the scene. So they get to a patient who's, in their judgment, doesn't need to go to the emergency room, at least not right now. They can connect to a physician via telehealth connection and see if the patient is amenable to care about telehealth, or they actually will make an appointment at some other resource down the road. That has not been as successful as you think it might be. Again, I think people are invested by the time the EMS folks get there. The newer version of that is to intercept the call at the 911 center. So for minor complaints, the 911 operator, instead of dispatching the call, will ask if the person's amenable to speaking to a nurse, and they get diverted to a nurse triage person, and the nurse triage person can help them work through the problem and is aware of local resources that they can send the patient to. And there's been good success with that in many jurisdictions across the country. Baltimore City is preparing to, or has actually cranked up doing this, and is looking to expand it. And a couple other jurisdictions in the state are interested in doing that as well. So we've been supportive of those kinds of things and trying to get them up and running.
Very good. Okay. And I'll take one last look. And I do not see any other questions. If anybody does, raise your hands. Dr. Delbridge, if you would like to do the outro.
Thanks very much for having me. It was great hanging with you.
All right. Thank you so much. Hopefully we'll have you back again. We keep doing these town halls. They're quarterly. So always looking to talk to leaders. So thank you so very, very much. And thank you all for taking the hour out of your night to be here. All right. With that, we'll call it done. Thanks again. Appreciate it.